You back there, calm down. Come join us here with, the rest of this lovely cohort. You two guys, there's like plenty of seats down here. Come on, don't be shy. Oh, look, I'm on the stage. You can see me from anywhere.
You look really good from up here.
Okay, so we're going to start the broadcast in about 5 minutes. That's going out to all of your peers throughout the country. And so we have several hundred folks on the broadcast and in the chat and all of that. So for you guys, it's going to be audience participation. So please do participate. Hopefully you prepared a bit. And when you speak, please project and speak loudly. And if you have your mask on and you speak, just pull it down for that long, and then you can put it back on. And feel free to wear a mask if you would like. What else? Okay, so we're going to go for about the first part is going to be about an hour and 10 minutes or so. And then I'm going to give you a break. And then we're going to come back for another about hour to finish up, wrap up. How are you doing up there? I see you. All right. I'll be like, you're there in the back because you're the highest right there. So I see you the best, as a matter of fact. All right. So yeah, please engage back and forth, and we're gonna have some fun with this. Yeah, everybody here to become a nurse still? Fantastic. So good. So good to have you. All right. Oh yeah, and the broadcast has a little bit of a delay. Right, just a few seconds. Okay, like 8 seconds delay. So when there's certain questions that people in the cyber, don't go far. Look, there's so many spaces right down here. Okay. I see. That's how it is. It's all about collaboration right there. Gotcha. Okay. Okay, so I will ask you to pause. There's certain questions that I'm going to ask. I'll ask you to pause a little bit so they can get their question posted to them on the broadcast, and they have the time to kind of go ahead and answer. And then we'll start while you're gathering your thoughts, and then we'll start talking about engaging on those answers. I'm going to, Nina, where are you? Or where are you going to be? Okay, are you going to be where? Here. Oh, you're going to be up here. Okay, somewhere here. Okay, great. So Nina is going to be monitoring the chat and questions, and so we're going to pause every once in a while and see what people in the cyberverse think and whether they have questions. Okay, any questions from you? Oh wow, crystal clear as always. Yeah, this energy is killing me, guys. Come on, wake up. I know it's Vegas, but, and I know this is like, time to go to bed, usually. But please step it up. There's coffee out there in case you don't have to pay for it. For real, they just give it to you. So if you need some more energy for that. So we're going to start. We're going to do something weird. Nina's going to introduce me. Like you've forgotten who I was from that last broadcast just recently. Okay, and then we're gonna go ahead and start. So about a couple of minutes, we're gonna get going. Everybody good? Everybody ready? Do you have your data with you? Okay.
I have a question.
Yes.
Why are we here?
Well, that's a good, I've been pondering that for close to 50 years now. And, as soon as I kind of started thinking as a child, I was like, interesting. And then why me is another question that's really, really good to answer. So I will answer it as soon as we get going. We're here to change the world. We're here to change nursing as a profession. We're here to bring health to everybody. That's what we do. We're the only school that does, as far as I'm aware, that does this kind of engagement and to put you on essentially the right track with your kind of going through the school, but then also with your practice when you get out. You had a question as well? Yeah, there's going to be assignments connected to this. And not just later on in this semester, you're actually going to have, I believe, a paper in your last semester that you're kind of going to synthesize all of this. But again, so this is to give you the baseline, the foundation, and then you're going to continue building on it throughout your program. And then, there's going to be papers. Woo! It's cool. Fantastic. So pay attention, take notes, get off your phones. Insta can wait. We can selfie later if you want, and all of that. Don't go that far. I can't see you. Come down here. Because now it's not lonely up there. So, all right. Okay. So let's get started, and I'll get down here for a sec. Or can I stay here? I can stay here, right? And then Nina. The focus is on Nina. Okay. Right.
Hey, welcome everybody. Can everyone hear me? Awesome. So I am Nina. I just want to welcome you guys here to the future of nursing. In case you forgot she's here, I'm going to quickly introduce our speaker, Mikhail Shneyder. So he is the president and CEO, board member, and a minority board owner of Nightingale College, a Salt Lake City-based private post-secondary distance education. Sorry.
You're good. I know.
Sorry. All right, so we're going to start again. So he's the president and CEO, board member, and a minority owner of Nightingale College, a Salt Lake City-based private post-secondary distance education institution dedicated to advancing geographic, demographic, and socioeconomic access to professional nursing education across the United States. A registered nurse for more than 25 years, Schneider has a wealth of management experience with secondary education for health professions and healthcare delivery services. He is a published academic author, conference speaker, and guest lecturer specializing in strategic planning, accreditation, forecasting, organizational development, and leadership. Schneider holds an MBA degree from UC Berkeley School of Business. Well, Mikhail.
Yay, thank you, Nina. Okay, so all the people in the cyberverse, bottles are falling already here in this lovely room in Las Vegas. So, obviously that won't stay here. It is out there in the cyberverse. Well, hello to everybody here. Hi, folks, on the broadcast. We're going to have some learning today. We're going to have some interactions and engagement. So for those of you guys out there, we're broadcasting, as I said, from Las Vegas. I've been here for a couple of days now together with our Director of Nursing Education Services, Dr. Audrey Auer. She's right there. Sorry, Cyberverse, you can't see her. And our Senior Manager of Partnerships, Julie Jenke. She's right there. So for those of you who are here in the room, we're going to stick around. You get some perks for afterwards for being here in the room with us. And so stick around. For everybody on the broadcast, this is a two-part workshop. We're going to go for about an hour and 10 minutes or so, and then break, and then come back for about another hour to finish up. Also, those of you on the broadcast, please remember to engage in the chat. We're monitoring the chat. We're monitoring your questions and comments, and I will pause every once in a while and ask Nina to help me with reading of the screen in the chat. Another thing to know for folks on the broadcast, throughout this broadcast, there's going to be, I will be posing specific questions for you, and that will be, I'm sure you got the instructions on how it works. You're going to see it in the pop-up somewhere, I think in Teams maybe, and then you answer the question and send it in, and we're both getting you engaged through that and also monitoring attendance. Yay, latecomers, welcome. Okay. All right, so everybody ready to go? Yeah? Okay, there's some thumbs up here. Pretty quiet, but I'll try getting you going. So, and can we get the slides up? Oh, it's the top. There we go. Boom. Can we do the show, actually? All right. So we're here to talk about the essentially the future of healthcare and the future of nursing in the country. Now, as you know, and I pose this question all the time in the New Learner Welcome Forum to sort of ask everybody of their perception of how we're doing healthcare-wise in the United States. And the answer, what is the answer that we usually get? How are we doing? Okay, this is now participation. You're here. Hey, if I see you in 3D, means you're here. So how are we doing? Not too great with COVID. Yeah, true. Yes, we could have done better with that. But set COVID aside, how we're doing. Okay. Okay, maybe is the right answer comparatively, right? If you take and compare us to some developing countries, say in sub-Saharan Africa, we're doing fantastically. Yeah. Probably not the right comparison group for a wealthy developed nation like the United States. So we're not doing that hot. And we're going to, again, hopefully you have prepared a bit, but we're going to explore how we're doing right now, look at that data. We're going to dig a little bit into the reasons we're not doing as well as we possibly could be, and then you will offer solutions, and we're going to talk about solutions that nursing specifically as the profession can offer the healthcare system. And what I want you all to pick up on, and starting today and then continuing throughout your schooling and into your practice, is that changing healthcare, making it better in the United States. No government is ever, the governments do not have, especially this politically, juxtaposed government. We do not have governmentally, politically enough tools and enough political will to change and improve the healthcare system in this country. Nurses, however, have every opportunity. And I really want you to really come out. If nothing else you carry out from today, I would like you to carry out the fact that you, as a nurse, both have the responsibility and the power to change the way it is and to make it better. And it's imperative for you coming into the profession to really understand that, and for the rest of your career and your practice to drive that change forward. Our people, our population, our communities need you to commit to that. So again, if nothing else you carry out from today, make sure you make a commitment to practice and through your practice, very deliberately change healthcare in the United States for the better. How many nurses are in the States? I know I asked this question in New Learner Welcome Forum, but how many? How many nurses are in the United States? Come on, participation. A lot. Well, sure. 100,000?
2 million.
I mean, okay, yeah. Wow, Vegas. There's some data going on, data-driven. Go higher. It's higher than 2 million. 4.5 million. Very good. Where are you? You're over there. Hey, you're like, and you guys wave because it truly is blinding here. So I can hardly see anybody, especially you up there. You know, it's like silhouettes. Anyway, yeah. So it depends on which count you look at. The latest puts RN workforce, just the registered nursing workforce, at right about 4 million. And then you have another several 100,000 of licensed practical nurses, licensed vocational nurses in the United States. If you start adding all of the other healthcare professions into this, we are, we're winning. As far as, although the shortages obviously exist because our healthcare system is structured differently from others, but in terms of having millions of people, we have them. We have them. They're practicing, 85% about actively practicing. The number is likely reducing now and has been reducing because of COVID effects. But here's the kicker here, is that Imagine if all of a sudden, overnight, all 4.5 million plus of us woke up and decided, I both have the responsibility, the power, and the skills, the expertise to change the system, to make it better for the population. Do you think we would be healthier as a nation? Absolutely, we would become healthier overnight. Unfortunately, that doesn't happen, right? So unfortunately, again, schools of nursing fail to convey this very simple message. Your practice and your license is not just about the person that you're taking care of directly right then and there. Your practice and your license is about improving health in your community. That is what it's about, driving that health forward. Again, and as you go through school, collect the tools, collect the skills, collect the knowledge, and then again, make the commitment to doing. Without us, without nurses, it will be failing over and over and over again, like it is now. So here's we'll go to this. Show of hands here, and those of you, you can think for yourself on the broadcast. What have you seen this? Okay, so last year, the National Academy of Medicine, previously known as the Institute of Medicine, has published its second report on the future of nursing, based on several years of research, and it includes, it's a big report, and by all means, I invite you and implore you and encourage you to go and read the report. It is really, really important for you as a practice, as a future nurse, to understand what's in it, to understand what recommendations are being made in order to make our country better, in order to make the health in the country better. But here's what it says. I'm going to actually read it for you. We will never thrive as a country unless we all have what we need to live a healthy life, no matter who we are or where we live. Let's talk about it. Do you agree? We will never thrive as a country unless all of us have what it is that we need in order to live a healthy life. I hear nods. They cannot hear nods on the broadcast. Just, audibly, yes, absolutely. We will never thrive until that happens. We're so far away from achieving that. That, what number 1 talks about, is called health equity. What is health equity? What is equity? The what? Equality and equity. Hey, latecomers, come on in. This side. Right around there. Go. Fast. Boom. No, not up here. Okay, whatever. So equality and equity is not the same thing. What is equality then?
All things said that they're equal.
Right. So everybody gets the same stuff, right? Everybody is equal and has exactly the same things, right? Look at it that way. That's equality. What is equity? It's something that builds over time, yes, but what is it?
What you put into it?
As if equality is everybody having the same, what is equity? Fair, right. It is everybody has what they need individually, or that community needs to achieve the same outcome as other communities are achieving. Does that make sense? So all of us have different needs, right? Different physiological needs, different stuff. We're different in that respect. So what we need to lead a healthy life actually is different from one another, from community to community. However, many of our communities do not get, and individuals do not get what they need in order to be healthy. Everybody, yes?
So then who decides what's fair?
Who decides what's fair?
Because
Well,
Walt's saying Walt needs $1 million a year for the healthy equity, and
Yeah.
Don over there may not think that at all.
But it's not right. So it's not the what, it's the outcome that matters. And we're going to talk about the outcomes. If achieving a certain level of outcome, because health is an outcome. Everybody is good of many different things, systemic things, individual things, family things, community things going to the pot. So that's an outcome. And the outcome should be the same. Health is what we're pursuing. Different people need different things to get there, right? To achieve that same level of outcome. This is an important concept. Everybody is with me on this? Yeah, I hear nods. Yeah, okay, yay. Now I hear the resounding yes. Okay, number 2, nurses are catalysts for this change. They're trusted bridge builders who collaborate with people, communities, and organizations to promote good health and well-being, no matter one's background. Ready? Feeling this one?
Yes.
Yeah. No matter your background, you deserve health as a human being. Everybody is with me?
Yes.
Oh, fantastic. I'm glad you're agreeing on that one. Okay. Now, and the last one, for our country to advance health equity for all, the systems that educate, pay, employ, and enable nurses need to permanently remove practice barriers, value their contributions, prepare them to understand and tackle the social factors that affect health, and diversify the workforce. That is exactly what we are paying attention to here at Nightingale College. Exactly that. Everything about how you're educated is different from how it's been done for decades and decades and decades, to make sure we arrive at a different outcome with you. You look like you're in prison now.
I'm gonna move.
Yeah, there's some bars, everybody up there. So, Anyway, okay. And this is so what you're carrying out from this today is sort of where we are, what our health outcomes are today, how much we spend on that, which is a lot, and then what it is that we can do differently in order to, what are the reasons for our performance currently, and what we can do differently in order to change the outcome, change performance, and change the outcome for everybody. Everybody good? All right. Okay. So let's dive in. Question number 1, for those of you in a cyberland, why is health important? And it's going into that Teams chat, I think, right now. This is the question for all of you as well. Why is health important? We're gonna, pause here, let you collect your thoughts, and then you're gonna start participating, correct? Awesome. Why is health important? Yes, please. Yes, so quality of life improves as health improves. What is quality of life? What's that about? Quality of life. Do you care?
Like being able to do what you want to do.
Exactly, being healthy enough, right? And having those health outcomes to be able to do what you would like to do with your life, right? Be it, with your children or whatever, hunts for deers. I don't know. But whatever it may be, it's quality of life. And then when you are unable, like many people are, to do things that you would like to do, that's where the quality of life tanks. And health plays a major role in that kind of balance or misbalance. Why else? Why else? Why is health important? Yeah, all of us. Look, nobody, as soon as you're, not like a young child mind figures out that one day I'm gonna go, from that moment on, you're like, but I want it to be as far in the future as possible. I want to live as long of life as possible, right? We all seek that. It is not, so yes, you're right. Healthier life means longer life. What else? Healthier life means what? Longer. Quality is there. What else? Contributions to your community. Absolutely. Healthier folks contribute at a much, much higher level to their communities. They're more effective. They're more productive at work. What does this translate to? If everybody is healthier in a nation, what does it mean for the nation? It becomes wealthier. Health drives national economies, drives. And we can do way better without it. Everybody is with me? Okay, great. So here's some of that stuff that we talked about. Anything else? Anything in the chat? Wherever Nina is? Yes. Thank you. Yes. Exactly. So everybody heard that? It cuts back on the expense, right? Health. You don't have to spend a lot on health, really. If you're promoting health in the first place and you're preventing disease in the first place, you're managing chronic conditions effectively, that costs much less than what we're spending now. We have built a very reactive system. So you're right, and then mental health improves. I mean, health and wellness itself, I'll come back to you in a second, just so that you understand, is multidimensional. It's not just about physical health, and not just about mental health. Those are only 2 dimensions out of 8. to really, if we're talking about wellness, if we're talking about human wellness. 2 dimensions out of 8. What are some of the others?
Financial.
Financial health, absolutely. How many of you can be like, yeah, I'm financially healthy? Yeah, exactly. Yeah, took me a long time.
Spiritual?
Spiritual health, absolutely. Important. Mental health, yes, we mentioned, absolutely one of the important dimensions. Emotional is the other side, right? So that occupational. Hopefully you are all getting into a profession that you will love and love practicing in and going and contributing and doing all of that. That's occupational health when that happens, when you really want to go and do it and engage, with whatever it is you do. So many dimensions to wellness. We're barely scratching the surface of addressing physical in this country. Imagine the rest. So there is a lot of work to do in order for us to get there. Let's talk about, though, change the gears and talk about spending, because that came up, right? So we get, and we'll look at the outcomes a little later. But I first would like to guide you through how much we spend in this country on healthcare, as compared not to developing countries in sub-Saharan Africa, but as compared to our comparison group, which is the Organization for Economic Cooperation and Development, OECD. So let's jump in. Let's look at it. So this is our healthcare spending, and this comes from the Commonwealth Fund. Anybody found this data? Okay, very good. Somebody prepared. Okay, a couple of hands. That's fantastic. 11. Right. So there's 11 countries on this particular list. This is 2019 data. It was published in 2020. It's going to be interesting to see the next iteration of this and how things have changed. But pre-COVID, pre-pandemic, see where everybody else is, developed countries, see where we are. So we were in 2019 at 17% of our entire economy. All the milk, all the cars, all the schools, all the service, everything. 17% was healthcare spending. That's a huge, huge number. And it's way more than the next highest is Switzerland. At 12, Switzerland gets for what they spend on their healthcare, gets way better outcomes, health and wellness outcomes than we do. So anyway, New Zealand, notice New Zealand. Probably, a little more than half of what we spend as a percent of the economy. We'll look at New Zealand's outcomes later. Just keep this in mind. All right, so let's break this down. Yes?
Aren't all 10 of those countries too, they're all like government-run healthcare?
That is not necessarily fully accurate. They have universal healthcare. They have universal healthcare. In some of those countries, it is not operated by the government, but the government is the single payer, right? So the payer is one, administrators are many. In some of those countries, like the UK, essentially the delivery system and the payer and all of that is within the government. And we'll look at those outcomes as well later as well, because comparison is interesting. Yes, so that's a good observation and something to keep in mind. We're the only country in this group who does not have a universal healthcare and single payer system. The only country. We'll look at the waste later in dollars. And I think you'll be shocked of what we waste in our system because of the way it is structured. But moving on. This is, I have an updated data for the US a little later on, and I'll ask that question later. But this is, again, back to let's see, the data is from 2019 for most of these countries. New Zealand, again, it's proportional kind of like to the other chart. We spend $10,000 in 2019, $10,637 per capita, means per counted person in this country. That's a lot of money. Now, did everybody have access back in 2019 to this, as a consumer in healthcare? No. So this, our spend per enrollee or per consumer in the system is even higher. But per capita, and look how much higher we are than anybody else. So that's something to keep in mind. Now, oops. Let's talk about outcomes. Let's talk about outcomes. And I'll throw a question over there on health outcomes to everybody. Anyway, so the question is going out there for you. It just asks simply about how we're doing generally. But let's talk about this. What is this? What does this tell you? How long we live? Back to that point, right? See where everybody else is? See where we are? The lowest. The lowest life expectancy at birth. We spend the most, we live the shortest. Winning! With those odds, I don't think Vegas likes those odds. Although the house is happy. Switzerland. Remember I mentioned Switzerland was right about 50% less than us on the relative spend. Quite a bit higher life expectancy than us. Okay, let's move to the next one. Winning! And this is 2019 data. The data, or 2017. Yeah, sorry. 2017. The data that will be coming out from 2021 is going to be staggering. So, again, how are we doing with mental health? Yeah, spend the most. Yay. All right. Adults with multiple chronic conditions. And this is the 2 or more of arthritis, asthma, or chronic lung disease, diabetes, heart disease, including heart attack, or hypertension and high blood pressure. We have 29% of the adult US population, more than one chronic condition. If you add the single chronic conditions into it, we're approaching half of population. Half. How are we doing? Yeah, okay, now I hear the correct answer. Yeah, relatively, right? For our spending and how many practitioners actually are in this country, we're doing relatively poorly in our outcomes. And these are big outcomes. These are like life outcomes that matter, really. Obesity rates, 40% of the US adult population are obese. And I know, we go into this like, my body, my choice, I can do what I want. Great. We just spend a lot. I struggled with weight my entire life. And it's a lot of work. And then when in my late 20s, hypertensive, on hypertension medicine, late 20s, smoking, because it's cool. Doing all of that, and then to actually stay healthy, it takes a lot. But just pay attention to that. Physician visits, yeah. Practicing physicians per population. We're on that end.
Because it costs $1 million to come talk.
You're right. Problems are systemic, right? They're not like, however, again, considering the power, and we'll talk about that later, because there are solutions. There are solutions to all this, but it will take some doing, and it will take some doing by the members of this profession and the medical profession and all of that. Nurse practitioners would be considered in this number as on the primary care level, right? We're nowhere near having enough nurse practitioners that can take care of families, that can be that primary provider, right? So there are solutions. It's just we're not really good at those. Okay, immunizations. We're actually one of the leaders in screening and preventative immunizations, except COVID. Everything else we do. This one somehow is like, nope, thanks. I'd rather die or be on a ventilator or whatever else. So and the point here to make is that the political just disconnect with actual facts and healthcare and all of that is staggering, and it's staggering on both sides of the aisle. It is just, I'm registering from everything. It's like I'll build my own party because that actually looks at evidence and facts and all of that, and then moves forward. Neither Republicans nor Democrats are using the data, the actual data. It took CDC forever to say, oh yeah, maybe we should look at it, rather than sort of the wishful thinking of it, and then on the other end, my body, my choice, never in my arm. I'm like, okay, well then let's make sure that we're considering overburdening the existing nursing workforce and making them quit because they cannot handle this anymore. They cannot handle the heartache, the emotional toll that it takes, the physical toll that it takes on somebody. Easily preventable. The infection is not preventable. Flu is not preventable. If you got a vaccine, your chances of dying are much less, especially if you're in the higher risk categories, which, half of the United States, if not more, is. Oops. Whoa. This is actually, again, because of our screening measures that are implemented, and I can tell you this much, women are way better in kind of paying attention and going like, I better go and check that. Guys are like, no, not around my back end. I will protect it at all costs. Colon cancer. This is the month of March. This is the colorectal cancer awareness month. Colon cancer, when discovered early, has over 90% survival rate. That is really, really high, but only if it's discovered early. Colon cancer is the #2 cause of preventative death in the United States. #2. Not around my butt. I'd rather die. Okay, well, free people, let's make our choices. Yeah? But why is that happening? Now, the prevalence among the US Black population of death from cancer, from colon cancer specifically, is tremendous. Much higher than in any other demographic group. It has a lot to do with many different facts. What is one of them? The what? Lack of health care, absolutely. Poverty, absolutely. right? Because if you can't do proper nutrition if you're poor. There are other, there are systemic issues that are involved in this, and lack of screening, lack of prevention, lack of practitioners that live in the community, look like the community, and are navigating, help community navigate through these screenings and healthcare challenges and so on. Yes, please. And there is no trust in the system. Absolutely, you're absolutely right. And again, there's quite a few studies in this nation on research on health outcomes and directly correlating health outcomes in any specific demographic groups, in any specific community, to the availability of providers that come from the community. Nursing, newsflash. Do you want to know? Do you know the numbers? Demographically, what we look like? How many percent of women? Oh, it's more than 80. It's more than 85. Yeah, it's getting probably around 85. So it depends again on which measure you look. But the latest I saw, one of the studies, 89% are women. Okay, that's why guys don't go, because there are no other guys to talk to them about that, the importance of doing that. Racially, how are we doing? What's the proportion? 80% of the US nursing workforce is white. 75% are white women. I have nothing against white women. They're awesome. They're great. They're just not as effective in caring for populations that culturally and from background-wise that they don't understand. It's very difficult for somebody who have never experienced poverty to guide somebody who is in poverty for better choices and health and all of that. Yeah, you had something. Yes, it is. Look, and again, it is, I want you to carry this out. It is your responsibility. I know you know a lot of glamour and that first paycheck gonna come and you'll be like, oh, heaven, compared to what I've done and what I've been. Fantastic, good for you. Yay. You're now taking care of yourself and your family. Do not forget to continually take care of your community. That's what's important. And again, you understanding this and you committing to it now, before you even, and I know many of you came to the school, it's like, oh, NICU, sick baby, I love preemie. That's awesome, fantastic. Maybe a couple of you will be out of the hundreds that we have on this broadcast. We'll go into that. Most of you, you're needed in community health. That's where you need it. That's where the real solutions exist and the real need exists. So think about that as you go through. I know ICU is all glamour, drips, and it's like, but hey, that some of you will do that as well. But it is better that somebody doesn't get into ICU in the first place. Agree? And much cheaper as well. Again, so think about that as you continue learning and going through. Yay! Diabetes and hypertension, hospital discharges. So Germany is higher. Why? Sure, but the Germans don't do, and they're like they're vegan, right? And sausage, absolutely. But our diets are probably comparable to each other. Why is Germany has more discharges? This is the discharges.
They survive.
Oh, survive, yes, thank you. That's a good point. And the fact that they have access to care, right? A bunch of people with these chronic conditions in the United States do not have access to care. That's why they're never admitted, never discharged. Everybody good? So we're still, let's not Germany skew your sort of understanding of where we are. Okay. So, and for that question that went out, it's that. Oh, I'll ask another question. It is the what is the latest U.S. spend per capita? Dollars per capita, and they have a multiple choice, so they can, like skirt the what it is. 12,000. Yes, it's 12,530 in 2020. 12,530. Do you see how much more that is than 10,600 something in 2019? The data that we looked at before. So yeah, we're winning in all of those things. I just want to point it out to you guys. Mortality amenable to medical care, we have the highest. Infant mortality, we have the highest. Life expectancy, the lowest. Suicide rate highest. Obesity rate highest. Prevalence of chronic condition highest. Cost-related healthcare access problems, highest. Healthcare system efficiency, lowest. Healthcare equity, lowest. How are we doing? Yeah, terrible. Now it's like, okay. And I don't want to be like all doom and gloom, whatever, but we have to paint the proper picture for you to have the baseline to start working from here into the future. And those of you who haven't engaged yet, feel free. What your head is thinking, because I know it's thinking, is valid. So keep bringing it out, keep talking. If you'll have to talk to those doctors and put your foot down and say, I know best right now for that patient, so please engage. Yeah, I'm not as scary as some of those doctors. All right. And then the spending. So it went up. 9.7% were uninsured in 2019, projected to reach 10.6% of the population by 2028. In 2020, it was almost one-fifth, 19.7% of our entire economy. So it jumped up quite a bit. Why did it jump up in 2020? COVID, correct. So we'll look at that. So the spend is there. And then it significantly outpaces the economic growth. All right, any questions or comments? Yes, please.
So by that point, they're all sick.
It is true. Our healthcare system is reactive. So you're absolutely right. We do not do a good job in promoting health in the first place, right? And again, and we do for many different reasons. Reason number one, nurses just don't think it's their job to do, right? Because they have never been expected or invited or taught that it is actually your job to do, right? So that's one of the simplest solution, and that's the invitation, right, that I keep extending to you. Take care of your community when you're, when you're out of school and licensed. You're gonna already start, if you learn something, it's like, oh, that's bad for you? Well, let me let my all Facebook friends know. Because that's not the greatest thing. The MARC, the colorectal prevention, right, and awareness month. Post on Facebook. Say, hi, if you're 45 or above and don't have family history, time to have the scope. If you have family history, it drops to 35. The prevalence of aggressive colorectal cancer in younger populations is up 57% in the last decade. This is people in their 20s, really, we're talking about, and 30s. Chadwick Boseman, heard of him? 43, died from it. Wealthy, right, whatever. Just forgot to, check it every once in a while. Anyway, so especially when there's family history. Anything? So going back to the comment. Yes, we do not do a good job in promoting health. We do not do a good job in preventing disease. We do not do a good job. Remember how many multiple chronic conditions? 40%. Half of the population at least with chronic conditions. We do not manage them well. Why again? Because nurses are disengaged from the management of, this is one really, and there's many other reasons, but one of them that hits close to home. And shoot, for you. Yes, somewhere here. And yes. Correct. There's no glamour in health, right? In kind of preventing something from happening. Drips are much more glamorous in the ICU, right? It's like, woof. Yay.
There's no money.
And there's no money in it.
There's no money.
Correct. And our system, the design of our system is set up as reactive. And that is why it is so expensive. Because it's much more expensive to treat something, to take care of something when it's completely out of control, right? So we'll talk about that a little more. So, yes, Nina. Okay. So, it's a trick question. But I'll answer it. So everybody heard it. It is about the ratios. Now, in my view, and this is just my view. There are different views out there on this topic. In my view, nurses must be making those decisions, and those decisions essentially need to be adjusted daily, if not hourly, right? Depending on what is happening in a specific facility, depending on the acuity mix of the patients that come in. And so there is not a one size fits all solution. So therefore, I think it cannot really be legislated because you cannot put every possible scenario into a legislation, right? And some states have done these legislations. The outcomes have not improved. It is, and again, too, the shortage really of providers doesn't care whether there is a legislation or not, right? Nevada. How is Nevada doing with the shortage? Nevada is number 49 in the United States in RN per capita. 49. Alaska is the only one that's worse. And Alaska is a big spread out state. This is much more, compact and kind of, the population is concentrated in certain urban centers. A lot of it. So yeah, it's and so I don't know if that's a satisfying answer, but other ways need to be found. And since I'll give any ideas of how you as a nurse can affect staffing and ratios in a facility. Yes.
Healthcare organizations and hospitals with nurses staff as a cost. So we don't see doctors as
Yeah. Yeah. Okay. So that's an excellent point. It is a cost center for facilities, right? So, and you have to balance your revenues and your costs and all of that. And people don't have the sound solutions. The bigger problem, though, These boards that you're talking about, how many of us are on them? You are? Fantastic. Congratulations. That's awesome. But that is what is needed, right? Nurses, this is one of those solutions. And this is one of those things that I implore you to go and do and start doing now. Build your credibility. Learn really, really well. Be an expert. And then push. You have to actively push to get on healthcare organizations boards, to get on the political boards, to get into unless we do, we're just and right now we're not represented whatsoever. There is some data that in the future of nursing that there's 5 times more doctors on these governance boards than nurses, whereas pretty much all of the healthcare facilities, they're nursing organizations. Everybody gets that? We are the largest workforce within any facility. And yet we are not represented. And we're not represented for many different reasons. One of them, again, being the fact that we never are asked right away, like in 205 fundamentals, whatever course you guys in, right? That's what you're in? Okay, yeah. That you must think about it now. You must educate yourself in a way and learn in a way that will allow you to sit on those boards, that will allow you to have a voice, and then allow you to create, to push different solutions into the organizations and restructure it. One of the, I don't know, you probably have seen our Core 7 framework. This is our kind of operational framework at Nightingale College. We have the vision of better health and better humanity for a better world. We have a mission that is centered on creating access to the profession. And then we have what we call the pathway. Part of the pathway is, there's only 3 things in it. Evolvitude, heard of this one? So how do we behave? How do we show up? Are we kind to each other? Same goes to you. Are you kind to each other? Are you kind back to faculty? Is that happening? That's just one word in there. But do you behave in a responsible, transparent way while building community with a growth mindset? That is important. So that's evolvitude. Collaboration is another. It's a team sport. All of it is. But the third thing, and really important thing, and this is why I am in front of you and am able to do this, because I've set out to build something different, something that constantly questions status quo and does not allow status quo to be if it doesn't need to be. So innovative design is one of those. And you're right, until and first of all, like this, I didn't crawl out of Mama's womb with all this in my head, and no, it's a lot of work, it's a lot of learning, it's a lot of doing, it's a lot of pushing, it's a lot of just going against the grain of regulation, of this, of that, of whatever, in order to be able to create something better and create something different and create something that can serve people better. And so, but without us having the seats, without us as nurses being CEOs of companies, not CNOs, CEOs, Chief Executive Officers, us being on the governing boards and doing all of that, we're not going to change the path. And no legislation, I'll give you this once again. We have tried it all. We have tried the same thing over and over and over again, and it has not worked. Waiting for unless we are all in the government, like Congress is like 50% nurses, would that be the day? It's not going to change. The government is not going to change it. Congress is not going to change it. They don't know how. They don't have the right knowledge, really. They watch the same news everybody else does. Turn off TV. I blame TV on everything. Yes, please.
They forget acuity of care. So some patients have a higher acuity of care.
Correct.
And we're not spending the right amount of time to require higher acuity. So they keep coming back because they're not getting the right care the first time around.
Correct. It's readmissions are a problem, right? The pushing people out are a problem because it's so it's so expensive. But again, the real solution to that is not going to come until less people with less acuity get into hospitals, right? Which means, again, the entire care paradigm has to shift upstream or downstream, essentially, has to shift to promoting health. And you as nurses are responsible for that. Preventing disease in your communities, helping people effectively manage their chronic conditions. That's where the answers are. Because if somebody gets into acute care, I mean, people, we are meeting over the past couple of days with partners here in hospitals, LTACs, and skilled care, and so on. And the acuity of patients just keep going up and up and up and up. So this should tell us something. It is not by accident that it keeps going up. It's by design. We're not addressing the root causes. We're not addressing the things that are preventable because, again, all of us, you watch your Grey's Anatomies and Chicago Meds and it's like, oh, it's so glamorous. That's what I want to do. No, nursing is not glamorous at all. It's smelly. Yeah. And it's like, it takes, resilience and perseverance and going and doing it and doing it and doing it and working with somebody and walking them by the hand toward that health. That's what it's about. I mean, I don't understand how city of Chicago stands still with, all the meds and fires and that they experience in that city. On TV, of course. Anyway, so now another question is going out to you folks, and that is a question on, So we're going to talk about who pays for Medicare. So how much do governmental agencies spend? And then we'll talk about the private care. So this is 2020 data. See those big numbers? Yeah, governmental agencies combined in that year spent, and this is just Medicare and Medicaid, there's quite a bit of spending that the federal government did directly, not through Medicare or Medicaid on COVID. Yeah, everybody heard of COVID. So the number is really big. $2.05 trillion. And trillion is a big number. And like try writing, it's like as a just thought exercise, whatever, just like to amuse yourself or your kids, whatever. Try writing it out, like with zeros. Go 0, 0, 0, 0. It's a long freaking zeros. And when you put a dollar sign in front of it, it's kind of scary. So 2.05 billion, and then the private entities, that's another question, spend about the same. So everybody, why is out-of-pocket decline in 2020? The what? Not necessarily. Yeah, well, not necessarily out-of-pocket decline because what? What was happening in 2020 with the population? Losing job and losing insurance. Yeah? Everybody remember that one? People didn't have access. And so the access declined, therefore the out-of-pocket spending declined because people were not, remember the proportion of uninsured went up. So private insurance declined as well because nobody was going to the doctor, yay! Everybody was like quarantined. Only people that, on ventilators and stuff, but everything else was, all elective surgeries stopped, everything else stopped, right? All of the things that could wait, essentially, that care stopped. So you have that there. Anyway, and Nina, let's go back to you. I forgot you had something else. That's funny. There are several nursing associations in the United States. The four biggest are called, for some unknown reason to me, the Tri-Council. They do some, so American Nurses Association, heard of that one? Yeah, the National League for Nursing, that's the Education Association. You have the American Organization of Nurse Leaders. So they do have some lobbying efforts, some of them, but it is not, it is not a kind of like a united, organized lobby like everybody else has. So, and that's why, again, we are disengaged. As individuals, we're disengaged as individual nurses. And therefore, if we decide to organize, wouldn't that be cool? And drive it, that's the power. 4.5 million people, that is about, more than 1%, 1.5% almost, of the entire US population. One nurse to less than 100 people. You think that's power? That's political power? Yeah, if only we used it and only cared enough to do it. So yeah, no. I mean, there is some, but not enough. Anything else, Nina?
What are the steps we as nurses take to educate patients about being healthcare?
Fantastic question. It's like, all those courses you're enrolling in. There'll be many answers there. Yeah, those are the steps. You have to know your stuff. You have to know the pathophysiology. You have to know normal physiology of the human body, right, and mind. And then you have to know the patho stuff. And then you have to recognize what's happening. And then you have to figure out, connect the dots together. That is why you're in school. You're not in school to pass some test. You're in school to learn and gain expertise to be able to be effective. So it's a very, it's a very long answer, what steps we could take. Step number one, learn. For real. Not going through the motions of checking off a box. That is not going to do anybody any good. It's not going to do you any good. It's not going to do the profession any good. And certainly it is not going to do your community any good. Time to stop posting on Insta, as we talked about earlier, or doing whatever else distractions you have. And focus and focus and focus. And then if something doesn't come right away, you figure out why not, and you go at it again. And if your desired grade is not achieved on the first attempt, don't worry. If you push through, you'll get there. But you have to do it. You have to learn. You have to connect the dots. I wish I could do it for you. Yeah, I keep talking about the, fancy myself a little bit of Harry Potter, and then, having the wand and going like, you get the knowledge, and you get it, and everybody gets the knowledge. Oh, I'd be rich. Just transplanting stuff. It doesn't happen. It's work. It's hard work. So, if still you're kind of in this, should I coast or should I not? Don't coast. Because again, your effectiveness is not going to be anywhere near at the level that is needed to be in order for us to make this better. Everybody good? Everybody's with me? That's a great question, and hopefully, you're okay with the answer. Yes? Skills is something that, as you practice and as you start performing on patients. By the way, again, don't think that you'll be able to get out there and all of a sudden like, bam, this and that, and IVs and catheters and da, and I'm going to be doing it all in due time. Some skills you may not actually begin to practice until you start practicing. right? And therefore there are some orientations with your employers and you know, but by the way, if you're uncomfortable with a skill, keep practicing on your modulars, right, throughout, and then make sure that the first time you do it, you voice that. And actually say to the instructor or nurse that's with you, I have never performed this. Can you guide me through it? Can you like watch me? Right? So a little bit of that confidence. And skill performance is just, again, you gain confidence as you keep practicing and performing. So that's one thing. Skills, though, do not begin to compare the importance of them to actually knowledge, right? To reasoning, to making the right decisions, connecting the dots, doing all of that. That's where the answers are, not in the skills. So the you know, we're training robots to do skills. There are actually companies that building robots to do like those, you know, lower level skills for you. Yes. It is a big deal. You have to be safe, right? We can't unleash you to for a learner, but for a practicing nurse, it's you have to be proficient in your skills, but you have to think about whether to do that skill or not, and what's connected to it or not at that particular point. So let's break. I see some bladders. You know, those are not nurse bladders. You got to train those things better. You know, you can't just like leave the floor and like, I'm done now in the middle of whatever. Holding is a skill. You know, there's no video for that, but okay. So I will see you all in about 14 minutes, so 35 to the hour, whatever time zone you're in. All right.
Okay, now, my first,
That's not a common time would be, it makes sense. They shouldn't be established. It's not complicated. We had the other.
Not bad.
What is that? Not for so well the first one. Oh, hey. I'm but because I know I'm kind of confused with what like happened. Like Google what happened, and I'm just gonna get to watch a bunch of like fun stuff in the second half. So I don't get it.
What is that? No, no, I was looking to see.
Yeah. That's fine. So just put it down. Yeah.
UHS system and a hospital teacher. Take my number, it's fine, get in. Director of PR, actually, director of surgery also.
Yeah, that's fine. Yeah, just pull it. If you have it like.
Hi. Yeah, that's it. You guys put it in. Yeah.
Yeah. Okay.
Okay, well, welcome back, everybody. Before we, and hopefully you're back there in a cyberspace, give you a couple of extra minutes. Before we move on, I want to clarify something. So just to make sure there is no confusion about what it is that I am conveying. There are the Future of Nursing report that I mentioned that is published by the National Academy of Medicine as one of the most important pathways to achieving health equity called for diversification of the nursing workforce in the United States. So are there any questions on that? Actually, let me answer again. Let me remind and reiterate why. Many studies on health outcomes and healthcare outcomes in communities draw the direct parallel between the background of the nurses and the outcomes of the population, that the health outcomes of the population and care outcomes of the populations that they serve. And the two are directly correlated. The closer the demographics and socioeconomic background of the provider, the practitioner, matches the population that they serve, the higher the care outcomes are and the cheaper the care is. Is that clear? And so the call for diversification of the profession comes from that fact. 61.6% of the US, estimated, of the US population is white. As we talked earlier, 80% of, and more than, a little more than 80% of nursing workforce is white. That means that the 38.4% that identify as other race are not as well represented in the profession as they should be in order to achieve health equity in this country. And let me tell you this. Health equity is important. Health equity and health outcomes across all communities in this nation is incredibly important to all of us as a nation. It is, we will never, if you go back and to that number one point of the Future of Nursing report, we will never achieve health equity. We will never flourish truly as a country until everyone in this country has health and has access to what they need to be healthy. Part of that is providers that represent those communities. So again, I want to make it clear. We need, we continue needing white nurses. Yes, that's great. But we need to continue diversifying as we grow the nursing workforce. We need to continue to diversifying it to truly achieve the outcomes for all communities. So I'm going to pause there. I'm going to ask if there are any questions. We had some feedback from the cyberverse that didn't take lightly to my comment about white women representation in the profession, that it's 75%. The gender representation as well. It plays a difference. Walter, I'll come to you in a second. Gender representation plays a huge role as well. We need more men in this profession in order for that health equity to start improving. It fit a little less than 50% of the population are male or identify as male, right? And we have the representation in the profession is nowhere near the diversity that there needs to be. Plus, addressing representation in the profession of non-binary or transgender communities is dismal altogether. And we have those populations, we have those communities that need to be taken care of, correct? And so, what the report is conveying and I'm conveying is that we have not done a good job as the population of the United States continue to diversify. We have not done a good job at all. And it's not my words, it's the National Academy of Medicine words in keeping with the diversity of the nursing workforce to reflect the diversifying population of the United States and to reflect the gender population of the United States and all of that, and socioeconomic population of the United States. We have the upper or middle class, and upper middle class represented much better than lower socioeconomics in this country, in the profession. So there are many reasons for it. But again, what we're doing at Nightingale is trying to change that balance, to try to balance it out. I'll give you our statistics. More than about 55% of our learner body doesn't identify as white. We're not doing that well on males. We're still kind of same place where the country is. So we need to do better in that. I'll come to you next, and Walter first. Go ahead.
So I don't think that, I mean, I did grow up pretty privileged for going through the Vegas, but so if you're saying that me, Walter, could like graduate nursing school and then say I want to move to like rural Alabama or rural Kansas or whatever and work in, the rural area, which usually for the most part are poor, then me as a nurse working there, because I don't understand them and they don't understand me, therefore the outcomes would be poor.
Outcomes will.
So even if, would they be better if I was there or if I wasn't there? Or
If you come, so what the studies say, if you come from the community and take care of that community, it is really about local communities, rural communities, growing their own workforces, right? And doing that, because again, the care both is more effective and cheaper. And it is, there are some comments about the trust in healthcare system that came out of why in Black communities, the health outcomes are lagging constantly is because of that, because the trust is not there, like in many other things. And so it's a systemic issue. But again, if we're able to develop more practitioners from those communities, the health outcomes in those communities will move up. Not to say that you shouldn't consider moving somewhere else and contributing somewhere else. It's just you have to be very, very aware of where you are, who you are, what knowledge you have, and then really build the bridges with the communities, truly understand the communities, right? And it's a lot of work. It's a lot of additional work. And if you just go in, just drop in, yeah, your effectiveness would not be. You can go through the motions of skills and so on, but true effectiveness and things like patient education, for example, are not there. If somebody, again, we talked about this, somebody has not experienced poverty, very difficult for them to really help somebody else navigate proper nutrition in poverty. And which again, and nutrition is really needed in whether you're poor or rich or whatever you are. Proper nutrition is needed for those health outcomes to be there. Okay, well, Julia.
I would never speak to anybody white until then in research, because I'm not in that category, obviously. But I can speak to being Hispanic and Asian background. The information is not out there for us. It's not out there for our patients. Yeah. There's a lot of misconception, a lot of misinformation, there's a lot of fear involved in healthcare and the way that people are treated. And I think just from past generations, somebody who's taking care of somebody else that looks like them, they're more inclined to trust them. I mean, The difference with me is I wouldn't sign up on company business. I would, but I was also taking care of too.
Yeah.
But I think that there's just a lot of things that go, how they're receiving the care, how they're shown to them. We don't understand unless we are in that situation.
Right.
Unless we're seeing from our own minds.
Yeah, and thank you. Yeah, absolutely. And so again, connecting those dots. Remember that I talk about. You learn a bunch of like theory and skills and all of that, and concept mapping and so on. Being able to adapt that. That's where the critical reasoning comes in. That's where some insight that you might have into a specific group may be very, very helpful. Kind of the understanding of the fear, right? The understanding of the misinformation, the understanding of all of that can be very helpful for you as a practitioner to adjust your practice, adjust your approach, adjust your care to a specific person. Because remembering that, you know, and this is the truth about the drips in ICUs, right? Is like many nurses and how the profession has evolved. We love technology. We love all of the machines. We love all of the skills, all of that. And we constantly forget that there's a human being right there attached to the orifice, right? That it's not just a mannequin to perform something on. It's a human being with their emotions, with their spirituality, with their connections, with their fears. And connecting on the human level, it's a tough skill to hone for anybody. But again, the better you understand a community, the better you perform. That's the bottom line of it. And we understand our own communities really, really well, right? I'm talking about the gender gap in nursing, right? Wow, it is some of these things like prevention of colorectal cancer. Oh, watch out. It's tough, right? It's tough for if you're not a man to convince another man to go ahead and do it, right? And have that conversation openly and talk about things that are taboo essentially in some communities to talk about. So that's what I'm talking about, right? So some of these skills, some of the experiences that we have, some of the cultural stuff that we carry is innate to us, but it's innate to other members of our communities, right? So that's where somebody who's not from rural, poor community. Wow, it is tough to really get to understand how life is and what it takes to survive and what it takes to try to be healthy, to try to take care of the family and all of that. So again, we understanding all of these and having these conversations is really, really important. And it is important, again, not my words, but the words of many, many people and researchers. Diversity in this profession matters to our country. It matters to the health of everybody. And the health of everybody matters to the economy. So it's like, it is all connected. The better we do, the more diverse the nursing workforce is, the better the health is going to be, and the better educated the nursing workforce is, the better the care is going to be, the better health outcomes are going to be, the better all of us will be. Because in a country that is growing, that is flourishing, whose economy is expanding, to populate, everybody does better. That's the point. And we want to get our country to the place of where everybody does better. And you, as future nurses, and you out there, have direct responsibility for that through the wellness, through the health approach. Anyway, I'll go here. Just another few. Oops. Let me see. It's stuck. Stuck. Yeah. Somebody help. The thing is stuck. Okay. So I'll actually, I have a copy here. I'll talk about it just briefly. See, this is being prepared. for the unforeseen. So then the next question is, who sponsors healthcare in the United States? Let's talk about that. Who sponsors healthcare in the United States? So we see, on that slide, it's let's see. Well, of course, it's off. Need to replace batteries. Okay, we're good. We're good. We're good. See, technology, me, not good. Okay, so this is the sponsorship of healthcare. Meaning, remember, like I said, governmental agencies have paid about, actually more than 50%. State and local, federal government, the spending grew by 36% in that year because of COVID, because of the direct, not through Medicare and Medicaid, but direct investment into, the testing, the vaccinations, the masks, on and on and on and on. The subsidies that went to healthcare providers to treat COVID patients, so on and so forth. So that's why the government, the federal government spending went up as that much. Households were spending a little bit more than previously. Private business declined, again, and we talked about that because their unemployment has increased. People lost their access to their employers' insurances, and therefore the employers themselves spent less on coverage than before. State and local governments, again, declined because of both decline in access and the step up from the federal government, right? So the states were using the federal money much more to address COVID and those issues. Other private, it's foundations, things like that, associations that contribute to payment. This is where the dollars went. Hospitals, acute care, still the highest at $1.3 trillion in 2020. And you can see, the $350 billion about in prescription drugs. We love our drugs. And so on. Dental services declined, again, because people were staying at home. Everybody understands that, and not seeking some preventative dental care and probably going more for the emergency things rather than just your regular checkups and so on. Home health care grew quite a bit. And why is that? Let's talk about home health. Why is that growing? Why? Yes.
So they would go home, hire more home health.
Yeah, exactly. So, and we've heard of, long COVID and things like that. And so some of these patients have been transitioned to homes and being taken care of by home health agencies at home. So that's quite a bit. But again, it's, if you see the proportions, this 3% and 5% and so on, nothing compares to 31% for acute care, right? And again, that number has gone up because of COVID, but the proportion even before 2020 it was quite high. And we talked about this because of the reactive care rather than preventative and proactive and things like that. All right, so now we're gonna look at this. This is, so these are estimates. These are based on 2019, not 2020. Because 2020, 2021, all bets are off. It's outlier years. In 2022, we're going to be coming back down in our spending, hopefully, because COVID is management of COVID is under control. Everybody here understands, though, right, that COVID is not going away. Yeah, everybody that genie is out of the bottle. It is going to stay with us. It is going to stay. It's going to continue mutating. All of that. Boosters probably going to be continued recommending same thing that we do with stuff like flu. And so so we'll have to learn to manage it without shutting down economies and doing all of that. And I think we're well on our way to doing that. Obviously, I cannot tell you enough about, and for you to take it to your communities, of how important vaccinations are in order to prevent severe disease, in order to prevent hospitalization, in order to prevent death. So your networks, continue pushing that. Against all odds, continue pushing that. The data is clear. The vaccines are safe. The vaccines are not experimental. They're fully approved treatments. So please continue spreading the word. So what stands out in that waste slide? Come on, anything like glaring, well, everything stands out, right?
Money?
Well, it's a lot of money. About 25% of that entire spending, right, which was about 3.6 billion in 2019. A quarter of that is estimated to, as much as a quarter of it, is estimated to be wasted in our system. Wasted. Nobody gets outcomes for it. It's just waste. What things that stand out from the list though? Anything? Okay.
Administrative complexity.
There you go. Administrative complexity, right? So this administrative complexity at almost, $300 billion. What does that mean? Administrative complexity. The what? Paperwork, yeah, exactly. Every provider negotiating with a bunch of insurance carriers, so on. Everyone has their own paperwork. It is an administrative nightmare, and it costs around $300 billion. No other nation on that OECD comparison list has this problem. Just us. And right, it's not going to care at all.
Okay.
Right, it is wasted because it is just the cost of processing claims and the cost of negotiating and the complexities that are built into the administration of healthcare in the States, right? So again, and the way others avoid it is through single payer systems.
So what is the cause of that problem? Like why?
Well, it's right there. It's so administrative complexity.
Yeah, why? Insurance.
Because we have multiple payors, right? Everybody understands. So there's the government that's a payor. That's universal insurance for the 65 and older and terminally ill people. Everybody understands that we actually do have a type of universal care in here, just if you're very sick or old. Yay. So it's not new to us, but we only insure through that particular universal care program and single payer program. We only insure the highest risk population. Imagine if a car insurance said, I am going to only enroll, like if you had an accident, come on over. If you had a DUI, you're my guy. I'll sign you up. Come on. I'll insure you. Do car insurance companies do that? Right. They don't want you if you're high risk. Same with private insurers in healthcare. They don't want you if you're high risk, right? But we do have universally insured population that is the highest risk, and it's paid through the government. And what in car insurance would be called risk pooling, meaning they will enroll some higher risk people, but it's offset by a bunch of people who are lower risk, who you probably won't pay anything for because, they're a responsible driver and they follow the rules and they will likely not get in an accident and all of that. And it makes sense. So they make money and people are insured, whatever. We created a system that come on in. You need your hips? This is your insurance. You need this? Come on down. And then excluded that risk pooling population that is younger and healthier and all of that out of that. So something to keep in mind, something to remember. But yeah, because of so many payors, insurance companies, payors, because of so many providers, again, that it's like there's no coordination at all in that. And that's why a lot of money is wasted on just coordinating that complexity. The over-treatment, you know, like in this nation, we're like, stomp up, foot down. It's like, I want that. Because it's on TV, right? It's a commercial. She's twirling in the hills. She's happy, you know, and it's like you go to a doctor if you have no idea of how much it actually costs. It costs you $10 with your copayment. You go to a doctor and you're like, I want that. I want to twirl in the hills. I want to be as happy as she is. And the doctor has exactly what, 2.5 minutes to spend with you, if that. Like, sure, just get out of my face. Here you go. Here's a script. So yay. It is failure of care delivery. This is these readmissions that we're talking about. This is stuff that could have been taken care of the first time around and isn't. And, because complexity, care coordination doesn't exist among the providers, right? We waste a lot. So this one orders an MRI and that one orders an MRI. And everybody does an MRI. And there's 2 MRIs on the same thing because there was no coordination between. Fraud and abuse, obviously that's there. Overprescribing, over diagnostics, the unnecessary diagnostics, all sorts of stuff that happens, and that's the number that we end up with. So we talked about some of these already, but let's dig in a little bit more into it. So see that top one? You've said it all along, right? The reactive system versus proactive promotion of health, prevention of disease, and all of that. This inadequate health promotion, and because of mistrust in the system, because of other things, because of poverty in this nation. Over 20% of all children live in poverty in the United States, below the poverty line. Scary. What kind of nutrition do you think they get? What kind of care do you think they get for their, perhaps the childhood acquired asthma? That is because the air is so unhealthy where they are. In Salt Lake Valley, in Wasatch Front, right, we have the highest prevalence of childhood respiratory conditions because we have one of the most unhealthy air in the nation. On some days, we rival Beijing. If you've never been to Salt Lake, is beautiful when the air is clear. But you can smell when the air is not, and you cannot see, like, across to the next building. It gets that bad. And so there's a bunch of environmental factors that affect health outcomes, right? A bunch of systemic factors, socioeconomic. The socioeconomic determinants of health, some of the highest reasons why certain populations are not and cannot get to good health outcomes is the socioeconomics, right? Again, it's if you're poor and you live in a poor and unsafe neighborhood, you probably cannot just go outside and kind of like stroll around, to get some activity as free as you would be able somewhere else. Again, buying food is an issue. And what's the cheapest, nutrition-wise? What's the cheapest? Fast food, junk food, cheapest, yay, processed food, all of that. Everything that is not great for a human body is the cheapest, right? Otherwise our lifestyle, how many times does it have to be repeated to folks that, popping on a thing, on a burning stick, isn't great for your lungs at all? It's like, oh, now we have a new thing, Seen those? It's like a cloud comes out. It's like, looks cool. Yeah. What it's doing to this thing? Not that great. But we're optimistic, right? That lady with a trach, permanent, breathing to it and then going, trying to speak through that. And it's like, oh, that's not going to happen to me. That's her problem. Well, we're very optimistic about our chances of, keep continuing the unhealthy behaviors, even those behaviors that have, like, pretty much everybody knows that it's bad. Stuff like that. Don't do as mommy does. It's not good for you. So what's your problem, mommy? There are ways to do it. So over optimism. Look, and I blame TV obviously for everything. Coca-Cola heard their latest thing. It's real magic. It used to be Coca-Cola is happiness. They've changed the tagline to real magic. I can bet you some magic is happening on your insides. Yep. Real magic. And they're like, sure, bring more. Let's have some. Big gulp. Yeah. Like all of the, everything, in addition to all of the sugar, all of the chemicals that formula is very highly protected. So is Pepsi's and others, right? It's like, we're not going to tell you what we're feeding you. It's real magic. And we're like, sure, yes. I want to twirl in the fields and the hills and sing. So the reactive system, it's built after the World War II. What problems were we experiencing right after World War II? Babies? Did I hear that? Yeah, baby boom. Babies were the biggest problem. There's a lot of them coming out right and left, everywhere. Bunch of guys got back from the war, and everybody went at it. Yay! So we built a system that, L&D, labor and delivery, normal labor and delivery, was kind of like the start of the acute care. And then, the population was younger through the 50s and the 60s, much more movement, more activity, so on and so forth, more dangerous jobs, not as much protection from OSHA, for example. So a bunch of injuries, you can imagine, right? So acute problems just happen. And then obviously, marketing agencies and the cigarette, for the lady has been introduced, and everybody, went to that and creating more and more chronic conditions as we moved along. Where, our lifestyles now is what? What do we do a lot? Sit! More than anything else, we sit. Not good for your body. Just not good. And I know, I'm guys asking you to sit here for like 2 hours. Sorry. But yeah, don't forget to get up and move every once in a while because that is important. But again, and we've gotten so far away from understanding that the prevention piece and health promotion is really simple, right? It doesn't take much at all. Sometimes it's more difficult. Again, I'm genetically predisposed to higher weight. I was like a fluffy kid, like very, and my parents put me in every sport there is. And I was like, nope, I don't like that. Nope, I don't like that. Tennis, I'm like, what? Too much movement. They found dancing, that stuck. So I did ballroom dancing to drop a few, but then, again, as I started not eating healthy, all of that. It still is work every single day. As a matter of fact, a bunch of us at Nightingale on a collaborator side, and we'll be rolling this out, not this year, but likely in the next year, rolling out this Wellevate program to all the learners. And so it is a pretty cool thing to kind of earn points and some gift cards and stuff to do healthier, to move around, to take steps. And yay, steps. You would think it's nothing. A bunch of research on how just mere 7,000 steps a day keeps your cardiovascular system in better shape. 7,000 steps a day. So, some days, I tell you, I'll be honest, some weekends I'm tired. I'm like 1,300 steps. Yeah. From couch to the bathroom to the kitchen. The sacred triangle right there. Yeah, Netflix. Anyway, so it's inadequate. The system is inadequate for today, and poor access. We talked about that, inequity that is within the system. The employers pay a lot of money. You saw that, right? They sponsor a lot of insurance, and yet they're completely disengaged from the health of their employees, and they continue paying more and more and more and passing, the premium shares and whatever onto the employees, but never asking for anything in return. Like Nightingale is doing with our collaborators. We're like, great. If you're not, directly in healthcare facilities, you don't need to get vaccinated. But guess what? The chances of us paying more for you are higher. Therefore, you're not going to get that premium break that other people get. Most everybody is vaccinated. Because they're like, why would I pay more? Same for steps. Yay, take some steps, get a gift card. Yay. As a matter of fact, so yeah, there's employers do not think in those ways. Nobody within the employers. Guess why we're doing it? Why is Nightingale that different from most employers in being an engaged payer for health insurance, for health? Why? Come on, take a wild guess. It is, but why are we even aware that we should be engaged?
Because you're in the business of training other healthcare professionals.
Good. Because the CEO is a nurse. Thank you. That's why, that's exactly what I'm trying to convey to you. You want change? You want better in your communities, in your employers, whatever? Climb the ladder. In order to do that, you have to know your stuff. Back to sitting on the boards, back to contributing in that, to reshaping, questioning the status quo, doing all of that. Because change is possible, change is real. It's just, unless somebody, you are actively doing it, it is not going to happen. We're in addition to being overly optimistic nation, we are, hope that springs eternal, right? We hope, we dream, we do all that, and then we don't do. To have those dreams, to have those hopes, to have whatever it is materialize. Like all of you have a dream, correct? A uniting dream among all of you. Everybody with me? What is that dream? To become a nurse, to get licensed as a registered nurse. Everybody with me in this room? Yeah? Okay. Maybe we have a couple of practical nurses there to get licensed as a nurse. That's my dream. Okay. Good for you. That's a good start. What do you have to do? Yeah. You actually have to go through the work, right? I mean, I wish I was Oprah. You get it, and you get it. I'm not. So, inability to access care, primary care provider shortage. We talked about that a little bit, right? How to improve that? Because physician education is long and very expensive, and is not necessarily what's going to solve the problem of primary care. Who's going to solve the problem? Nurses, correct. Ever heard of family nurse practitioner? Fantastic. We're starting our FMP program in the summer. Don't tell anybody. We're not advertising it yet. It's going through a final stages of accreditation approval. So, but chances are we'll get it, and so we will be able to start it. But for you, it's no matter where you start. You start as practical nurse, vocational nurse, and then continue to associates. We reintroduce the LPN to associates bridge that is starting in the summer for sure, and that's on the website and all of that. And then associates to bachelors, and then go for your masters. The more of us are prepared at the graduate level, even at the bedside, the better the outcomes will be. Leadership. We need leaders across we need primary care providers in a rural community that we talked about before. The lack of primary care is staggering in many rural communities, and so here in Nevada as well, right, as well as across the country. So making sure that we can staff primary care with family nurse practitioners. It is not only the most effective, cost effective, but also the most outcomes effective way for primary care, the most caring way to primary care, the most guidance, all of that. Nurses have that within, that compassion. It's not about cutting something up, like, ooh, and like digging in cavities. Like doctors do that. They love that. We connect with human beings. We create those connections. We then guide them. And we can drive their health for the better. We can guide them in that. Yes, please.
So my fiance, like, he's going to become a cardiologist. So I'm like, babe, you want to become a nurse? No, he tells me I'm compassionate, so nursing is great for me, but he's not. So he's a nurse.
Compassion. You're absolutely right. That's one of the, first of all, I was asked by one of the partners in here in Vegas, just visiting yesterday, to make sure that everybody who enrolled in Nightingale College understands that nursing is not medicine. Yeah, it's like different things. Yeah, different approaches, different practices, compassion being the core of nursing care. Compassion, right? Connecting with humanity, connecting with human beings, understanding human beings, and you will be working with human beings. And when you, like, especially in acute kind of situations and all of that, work with human beings, oh, they not only, there's all sorts of unpleasant smells. Get yourself ready for that. But it's like one of the worst days they've had in their life. So their behavior is not the greatest. And what compassion means is you understanding where they are. You as a human being connecting with them and then saying, that's okay. I understand. I'm not going to react to you because I know you're having a bad day. I know you're hurting. I know all of this. I am here to support you. I am here to help you. I'm here to guide you through this. And you can make it. You can do it. So that's always an important piece to remember. And we're the front line. We're always there when the patients are, right? And so the more of us out there, the more of us in the community, the more of us are in public health, the better our communities are going to be. Oops. Okay. Quickly on that, unnecessary care. We talked about that, right? What do people get paid for in healthcare facilities? Doing stuff. Precisely. The more you do, the more you get paid. Correct? The more revenue comes in into the facility, whether that doing is needed or not. Everybody good? So there's and that's kind of captured in a waste. So we pay per service mostly instead of paying for outcomes, paying for performance. That started changing with the Affordable Care Act introduction and changing how Medicare which is the largest payor, single payor in the United States, how Medicare approaches payment to providers. It's care bundled now. Essentially, you get a payment, get the outcomes. We're paying you for this, and if you didn't do a good job the first time around, provider, and somebody is readmitted with the same issue, guess what? It's on you. Get the outcomes. Figure out how to do that. Get nurses into your boardrooms so you can talk sensible staffing. Correct? There you go. So that's there. Overprescribing, again, I don't know how, nowhere else is are drugs advertised on TV. It's like Magic, Real Magic, Coca-Cola, and then Ozempic. Just, oh, I need that, right? Yeah. Sounds like my skin can use Ozempic. And Ozempic is expensive. Unnecessary diagnostics, lack of coordination, provider shortages, and litigious society. Right, a lot of healthcare providers and they try to avoid being sued. So again, they sort of do what's demanded rather than what is evidence based. And again, unfortunate, and we have to start re-educating the populace, right? That when you're having a common cold, or COVID for that matter, an antibiotic will do absolutely nothing. Although you may stomp your foot like my mother. I have had this for 10 days now. It's time for antibiotics. I'm like, mother, no. This, what you're having is, but what mother does, 2.5 minutes with the doctor and is like, get a script. I'm like, oh. She's like, I'll save it for later. Whatever, okay. Sure, and let's create more antibiotic resistant infections through that. So, but again, because the doctor, she literally has no time. And then mom's doctor, she said, well, like this cardiac problems that you have and spine things and whatever, you should lose some weight, and it'll be better. Oh, my mom didn't like that. So she can look at herself. Mother, she's advising you. What she does, whatever, that's her choice. You make yours. Yeah, it's tough. Anyway, talked about administrative costs. That third bullet we've discussed quite a bit, and no comparative shopping, right? Those who have insurance in this country have no idea what things actually cost. Most people. So because you have a $10, $25, whatever dollar copay, and you go, and it doesn't matter that your payor will pay thousands for that particular thing that you're doing. And so on Amazon, anybody shopped on Amazon? Yeah, okay. Everybody shopped on Amazon. You know how you will go and search for 2 cents less for the same product? Exactly the same, but somebody else has it for 2 cents less. Which one you buy? 2 cents less. Well, the quickest to, Prime is there, well and alive, but there is no such comparison shopping going on for, and I'll give you an example. I had to have legitimately an MRI of my shoulder done several years ago, and I actually shopped, and the same exact service ranged anywhere from $756 or something like that to over $5,000. So my insurance was paying, but I made sure to go to the provider, which was just lovely, great care, same results, MRI, it just cost much less.
That's the problem with only not having one payer. That one payer says, hey, this is what we're
right, exactly.
An MRI is an MRI. They're
right.
doing it different, the machine's not identical.
Exactly. It takes the same amount of time.
Correct.
Yep. Exactly. So that's but again, in our society, the single payor is a political non-starter. universal health is a political non-starter at this point until 50% of Congress is nurses. Then we're like, yay, we're going to do it. So that's the next best thing, to educate consumers on price comparison. Some insurance offers that already and is built in. Lack of effective health education, we talked about that. Nurses, there's so many nurses, and they don't educate, right? They just don't make it their business to educate their communities. Friends, whatever, family, start there. Go out further. Sedentary lifestyles, we talked about that. So I'll open it up. We'll see if there's any other comments on in the cyberverse. We'll open it up here for discussion. We've talked through, as we were going through this, about many solutions to this, right? That hopefully, as nurses, you will be taken to heart and moving forward. Let's just summarize, like what have you picked up? What it is that, and the question becomes, I'll make it more personal to you. Not just what you've learned, what are you committing to? As a result of this discussion that we've had, and the data that we looked at, and the information that was presented, and sort of the discussion that we had on possible solutions around where we are, and we started like from okay to terrible with healthcare, remember in the beginning? We're doing okay. Oh, well. Okay is not good enough. What will you individually commit to at this point? And I would like to hear like from more of you than just, those of you who have been engaging throughout, thank you. It's always great to have, folks that contribute. But everybody else, come on. Educating and advocating. Can you expand just a little bit on that? Yeah. Okay.
Sure that, if there's something available to them, they for that bridge.
Yeah, fantastic. So it's educating, and what you're describing essentially, it's committing to being an advocate, right? For that human being that you're working with, and connecting them to resources and doing all of that. So that's great. What else? Other things. Did you have a hand up? Yeah. Being a leader. So leading out on much of this stuff, right? The things are not, the system itself is not going to change miraculously. We can wish and hope and dream and pray all we want. It is not going to until we do, until we actually take an action on it. So becoming, making sure, leading out. And you can lead out in many different ways, right? You can lead out at the bedside. You can be a champion right there. What your title is not as important as your leadership and what you do and how. And then trust me, the titles and all of that and the letters behind your name gonna come as a side effect of you leading out. Other things.
Being a voice.
Being a voice. Yeah, talk more about that.
Like being an advocate for the patients, as well as for myself, I'm a CNA, and I'm an advocate for the patients as well as for us as CNAs. Because we don't have enough CNAs on the floor, and our patients are the ones that suffer from that.
Yeah, the low CNA workloads are, we just talked about it. Yeah. And the patient incredibly high. The CNA workload is just incredibly high, and it is, people, it's unglamorous. It doesn't pay.
Being a nurse, believe that being an RN, you can be a voice. It's up here, nothing will change down here, and ultimately, it's about patient care, right?
Yeah. Ultimately, it's about the outcome, right? Care is the means to the outcome. And exactly. And so, but if you set your sight on the outcome, then your care follows, right? Your care then leads to that outcome. And so it's not doing for the doing's sake, it's doing to achieve an outcome and not giving up when the first time around or the second time around you're not successful at that. because you have to adjust. Do not try the same thing though. Like adjust something in your approach, and then, but being an advocate for patients, being an advocate for the profession, great. Leading out. I'm looking for one more specific thing. Oh, well, go ahead, please.
Not, but I'll say like being outstanding nurses, like being the best nurses.
Yeah.
Yes. Why being more oriented, yes, on purpose and providing quality.
Yeah, being an outstanding nurse. How do you get to being an outstanding nurse? Yes. So that compassion that you have to bring in confidence to it. You have to bring in competence to it. And those two things come from your education, from your learning. Learning is your journey. We're here again. I'll say it once again. We're here to facilitate that for you. The journey is yours. We cannot take it for you. So being very, very deliberate in that and really dedicating yourself to that, that's what's going to then have you become an excellent practitioner, and then achieving all of those things that we need you to achieve in your practice and in your communities and in your care. And please.
We talked about how we step away from the humanity. That's the most important thing, is to remember that our patients are still human. They have families outside of our care, and we need to treat them like that.
Absolutely. That's a great, absolutely great point to end on. Remember that, you know, enrolling here, you are, and I invite you all to see that vision of better health, better humanity, better world, no matter what is happening, no matter what, you know, and some horror is happening in the world right now. Some horror, if you have been paying attention, it's happening in Europe, in Ukraine, and it is because we have lost, not only we've forgotten to see it in other people, see themselves as human, see them as human beings, we lost our own humanity too, right? And so it's our ego is the rule of it all, and we forget that we're so universal, we're so one. We're experiencing the joys and the pains in exactly the same way. So seeing that is called compassion, right? Seeing that another human being, recognizing yourself in them. No, absolutely. The golden rule is great, but it's seeing that, knowing what it feels like to, because you do. As a human being, you know what it feels like to be human and what others may be experiencing. And then again, supporting them in that experience is really, really, really incredibly important for for our you know, healthcare, for our communities, again, for the nation, for the world. It's really, really that. And nursing is really, really that powerful. So thank you for engaging. Thank you for paying attention. I wish you all, and Cyberverse here, the absolute best in your educational journeys, in your careers, in your practice. And then we'll, you know, I'll be, I guess, see you around at some point. So thank you so much, and flame forward, everybody. Thank you. Stick around, you know,